Hello. Today we will be discussing venous thromboembolism, also known as VTE, and you will be hearing from multiple speakers today, including Madeline Beiser, Josh Joseph, Neil Kaisman, and Heather Trin.
Okay, the objectives for the PowerPoint are to understand the pathophysiology related to clotting factors and venous thromboembolism, describe and explain VTE prevention for inpatient hospitalizations, and describe and explain VTE treatment for inpatient hospitalizations.
Healthy People 2020 focuses on identifying significant preventable threats to everyone's health and establishing goals to help reduce them. Hospital-acquired VTE happens to be the leading cause of preventable deaths in the U.S., and each year, as many as 900,000 Americans are affected by it, and about 100,000 result in premature deaths. As many as 70% of these cases are preventable through preventative measures. So, how do we prevent VTEs from occurring? That is why Healthy People 2020 came up with the goal to reduce the number of adults who develop VTE during inpatient hospitalizations.
When thinking venous thromboembolism, it's imperative to remember Virchow's triad. Virchow's triad just breaks down the three components that lead to development of a venous thromboembolism. The formation of the clot is very unlikely without all three of these factors present. The three factors are venous stasis. So you don't want your blood to kind of be pooling. You want to make sure you have a constant, the blood constantly moving back up into the right side of the heart, to increase the cardiac output, keep the blood moving to avoid any clotting. You're going to be in a hypercoagulable state, so anything that's going to lead to increased coagulability of your blood, and endothelial damage. So if you look at endothelial damage, the endothelium is the inside lining of the blood vessels. There's two boxes. You have one that has smoking and hypertension, which is not all of them, by the way, and another that has, surgery, PICC lines, things like that are more physical traumas. One box is kind of damage coming from inside and of the blood vessel, and the other is damage coming from an exterior part of the blood vessel. And this will be important when we go into the following slide talking about the blood clotting pathways. So now I'm going to get into the blood clotting pathways. So coagulation of the blood, or blood clotting, can be initiated by two separate pathways, which then lead into one common pathway. And I put a chart in here to kind of break it down. This isn't the full chart. This is a very simplified version of the coagulation cascade. Either way, there's two ways it can start: through an intrinsic pathway or an extrinsic pathway. So intrinsic is triggered by direct damage to blood vessels, and extrinsic is triggered by damaged tissues outside of the blood vessels. So yeah, going back to the Virchow's triad slide, where there was the two boxes of endothelial damage, one was endothelial damage and one was endothelial dysfunction. The dysfunction would more likely be an intrinsic pathway, while the damage would be an extrinsic pathway. So they both lead to the common clotting pathway and the production of prothrombin activator. So prothrombin activator then converts inactive plasma protein prothrombin into an active enzyme, thrombin. Thrombin then transforms your soluble clotting factor fibrinogen into its insoluble form, fibrin, which makes cross-linked fibrin mesh, or a blood clot. So now moving into venous thromboembolism pathophysiology, there's a few ways that it can occur. It's important to know that venous valves are avascular, which in conjunction with reduced flow of oxygenated blood in veins predisposes the endothelium to be hypoxic. So the endothelium around the valves responds to this hypoxia by expressing adhesion molecules that can attract leukocytes. These cells transfer tissue factor to the endothelium, which can complex with activated factor 7 to begin coagulation cascade, and this would be via the extrinsic pathway. This is not the only way. This is just the most common way. It can be from the intrinsic pathway that you have a clot develop. The main component of the thrombus formation is fibrin and red blood cells, which get trapped to the clot. Platelets can contribute, but to a lesser extent, and it's less common to see. It's mainly just fibrin meshed with red blood cells. Your muscles are really designed to help avoid this by pumping blood whenever your muscles contract back up to your heart. So this is what I'm going to refer to as like the skeletal muscle pump. So the skeletal muscle pump can help you prevent VTEs by moving blood past the valves. And the valves is where blood can really pool, because once it gets past the valves, it'll push back down because gravity would push it down. So by muscles contracting, you're reducing venous stasis. In addition, you can wash away the activated clotting factors that can otherwise propagate the initial thrombus formation. So this is why movement is very important in avoiding venous thromboembolism. So having your patients do something like just contracting their calves through plantar flexion and dorsiflexion can really help, because that can move the blood that's pooling through their veins, which can to get rid of one of the three things that contribute to Virchow's triad. So if a clot does form and it doesn't resolve, after a few days it can extend proximally into the popliteal and femoral veins. About 25% of your calf VTEs will extend proximally within 7 days, the ones that stay in the calf can be asymptomatic and not give rise to significant pulmonary embolisms, except the ones that do extend proximally, they're much more likely to be symptomatic and can embolize to form dangerous pulmonary embolisms.
Clinical manifestations and complications. Some manifestations are calf pain or tenderness, swelling with pitting edema, increased skin temperature, superficial venous dilation, cyanosis occurring with severe obstruction. Patients with severe VTEs may have fewer leg symptoms, while pain, tenderness, or swelling of the lower extremities could be caused by other disorders such as a hematoma or Baker's cyst. Some complications, pulmonary embolism. So you want to monitor for shortness of breath, pain on inspiration, coughing up blood, or feeling of impending doom. Another complication is post-thrombic syndrome. This is a long-term complication of DVTs occurring from damage and incompetence of venous valves, causing stasis of the blood in the lower extremities. Some signs of this would be chronic swelling and skin changes in the affected limb.
Hospitals' current VTE prevention guidelines include mechanical and/or pharmacological interventions. The use of graduated compression stockings and intermittent pneumatic compression devices, along with venous pumps, are highly encouraged. Early ambulation and passive and active range of motion are exercises that could prevent stasis of the blood, which then results in the prevention of VTEs. With pharmacological measures, anticoagulants are golden standard in hospitals. Lovenox is the most known and widespread medication used for VTEs, but there is also warfarin. Both of these interventions are used in conjunction with each other to promote the optimal prevention of venous thromboembolism. Studies have shown that mechanical prophylaxis is less efficacious when compared to anticoagulation-based therapy. But with mechanical prophylaxis, there is no threat for bleeding precautions. Whereas with pharmacological interventions such as Lovenox or heparin, there is a higher incident of bleeding chances. Some issues that can arise with mechanical prevention would be skin breakdown, so you would have to assess for that. Other issues would be patients find them uncomfortable and they can disrupt their sleep. They can also be loud and they can just cause discomfort in general. Also, if the staff did not put them on correctly for the patients, could be an issue. There has been newer research coming out about the use of factor 2A and 10A oral anticoagulants instead of warfarin and Lovenox. Bavixa was the first factor 10A inhibitor approved by FDA for VTE prophylaxis. It has a quick onset of action, and the time it takes to reach the maximum plasma concentration is 3 to 4 hours. Another study done was with Xarelto, Eliquis, Savaysa, and Pradaxa in comparison to warfarin, and the study showed an overall incidence of stroke and an embolic event were significantly reduced among the factor 10A inhibitors. Thrombin inhibitors like Pradaxa also showed reduced embolic events, but not as significant. Both thrombin inhibitors and factor 10A inhibitors showed a reduction of hemorrhagic stroke relative to warfarin. Another study compared Xarelto and Eliquis with low molecular weight heparin in acutely ill medical patients. The conclusion was that there was no added benefits from taking the oral anticoagulants over the low molecular weight heparin injection. As these oral anticoagulants may not replace the use of Lovenox, they offer a more convenient and less anxiety-ridden way for preventing VTEs.
The table we have here shows the total number of doses ordered, number of ordered doses not administered, and number of doses not administered and documented as refused. So if we are able to increase the amount of doses administered, it would in turn reduce the number of patients who developed VTEs during hospital stays. Addressing the multiple issues that can lead to patient refusal or doses not administered is the first step in fixing the issue here of such a high percentage of doses not being administered. For diagnostics, we have the duplex ultrasonography, and that uses two modes of ultrasound. The beam mode finds images, and then the Doppler shows the velocity and direction of the blood flow. It can show structure and location of occlusion, and it's a non-invasive test. The D-dimer is a blood test that can detect FDP, which is a small protein fragment that breaks off from any clot after fibrinolysis, and a positive result indicates the thrombus has formed, but it can't indicate location. And if you have a negative test, it's highly unlikely that a clot is present. And a positive test does not necessarily mean that a clot is present, but it does indicate that a patient needs further testing. And then the contrast venography has the type of X-ray, and they use the dye, and it can be seen on the X-ray, and it's contraindicated in clients with allergic reaction to contrast dyes or iodine or kidney problems. It can confirm a diagnosis of a DVT, and it's used more than just for a diagnosis of DVTs. It's used for other imaging for like congenital issues or finding a vein for vein grafts. And if you have a problem with any of these testing, you can use MRI or a CT scan. It can visualize the thrombus in central veins and can be used for further imaging. And then for pulmonary embolism specific diagnostics, you would use the CT pulmonography angiograph, and that's first line imaging for PEs. And at first, it was an alternative to the ventilation perfusion scan. And the ventilation perfusion scan, or the VQ scan, examines blood flow in the lungs, and it's a nuclear medicine scan. It can detect PEs. It's a type of X-ray, and it takes about an hour with the client lying very still. And then the pulmonary angiography is another type of X-ray test to visualize pulmonary arteries and veins, and that uses contrast also. For VTE treatment, we have that early detection and treatment leads to the best outcomes. And then if they're on anticoagulants, you want to continue or initiate if they're not on. And that keeps clots from continuing to form. And then for thrombolytic therapy, you would want to use the TPA tissue plasminogen activator. They have the inferior vena cava filter or the IVC filter. And then for like the last ditch effort, you would do a thrombolectomy or embolectomy, which is you can do surgical or through a catheter. And then if it leads to a pulmonary embolism, you're going to want to treat with oxygen along with all of the other treatments. And then you want to monitor hemodynamic stability. And then for treating with anticoagulants, heparin has a short half life, so it's optimal if client may need thrombolytic or surgery to treat the VTE, such as an IVC filter or an embolectomy. And you want to monitor the PTT. And then you would also could do the low molecular weight heparins, which would be like Lovenox. They have newer drugs such as the synthetic anticoagulants or like something like Xarelto. And then the thrombolytics are considered to be like busters and they dissolve the clots. They need to be administered before permanent damage has occurred. Also, for the thrombectomy and embolectomy, they're more rare and they're for patients who are hemodynamically unstable, who had failed thrombolytic therapy, failed catheter treatment, or it's contraindicated to thrombolytics. They have high mortality rates also.
What is the nurse's role in VTE management? The roles of the nurse is being able to identify risk factors such as patients who are postoperative, immobile patients, stroke patients with lower extremity paralysis, or patients who are critically ill in the ICU. Knowing preventative strategies such as exercising daily, adhering to medication therapy, doing their medication reconciliation, so knowing if they're taking any herbal supplements or hormones that can increase their risk. Being able to identify signs and symptoms varying from calf pain to warm, swollen lower extremities or cyanosis. Implementing different non-pharmacological therapies such as SCDs or TED stockings, and knowing different pharmacological therapies such as anticoagulants or statins, along with the complications of a VTE, which are pulmonary embolisms or post-thrombolytic syndromes, and being able to assess them. Nursing interventions vary from knowing different diagnostic studies such as an MRI, CT scan, or ultrasound, and knowing laboratory values such as a positive D-dimer, being able to initiate treatment and knowing their adverse effects, and reassessing for complications throughout the hospital stay. Patient discharge education. Education includes teaching of signs and symptoms of a recurrent DVT and bleeding risk precautions, the importance of obtaining a MediAlert bracelet. This bracelet should have the information of all anticoagulants that are being taken, along with medication treatment or teaching. Has the objective been met? Yes, it has. As you can see on the chart, since 2010 to 2016, the incidence of hospital-acquired thrombosis have significantly decreased. This is due to the increase of diagnostic studies and their availability, the use of risk assessment screenings, and the education on preventative strategies. In conclusion, with the combined efforts of implementing all these techniques, this will drop the VTE rates even more.